everyone, welcome back. As promised, I will be doing this video on pulmonary embolism or PE. If you haven't seen my video on DVT or deep vein thrombosis, I will provide a link in the description box. Go check it out. It has very relevant information about many of the anticoagulants and therapies that we use in PE as well. Venous thromboembolism, or VTE, is the umbrella term under which DVT and PE fall, and VTE is a condition in which blood clots form in the deep veins, and that's called DVT. And then if that blood clot breaks off and travels in the circulation, it can eventually lodge into the lungs, and that is known as pulmonary embolism or PE. This can obstruct the pulmonary artery or one of its branches, and all of that can lead to significant morbidity and mortality. PE can be acute, which means that the symptoms develop immediately after obstruction. It can be subacute, meaning it can take days or weeks to develop following the initial event, or it could be chronic, where symptoms of pulmonary hypertension develop over many years after the initial event. So, the risk of recurrent thrombosis and embolization is highest in the first few days and weeks after diagnosis. So it's very critically important that these patients are diagnosed properly and on time, and that we initiate treatment as quickly as possible. All the specific risk factors in the development of PE or DVT actually fall under three factors that are known as the Virgil's Triad. These factors are venous stasis, activation of blood coagulation, and vein damage. So all of the known risk factors, or the specific ones, will fall into one or more of these basic factors. And some of the well-known risk factors are history of immobilization or prolonged hospitalization. That's why many of these patients are provided with thromboprophylaxis, recent surgery or trauma, obesity, history of VTE, malignancy, which is a hypercoagulable state, age over 65 years, family history of VTE, and pregnancy or postpartum state, which is also a hypercoagulable state. So, what is a typical presentation of patients with PE? And this can be the tricky part because the clinical presentation actually falls on a very wide spectrum. Some patients have no symptoms. Some patients can have symptoms of dyspnea or trouble breathing. And some people can actually be in shock, or it could cause sudden deaths. So, again, that adds to the importance of really making sure that PE is diagnosed on time and treated appropriately. Some of the most common symptoms in patients who do have symptoms are dyspnea, chest pain, which is typically pleuritic in nature, cough, and they may also present with symptoms of DVT. So if you have a patient who presents with these signs and symptoms of PE, how do you then proceed to make a definitive diagnosis? Well, the first thing you'll probably do is get a D-dimer level, which can be obtained with a simple blood test. A D-dimer is a degraded product of cross-linked fibrin and is elevated in almost all patients with acute DVT or PE. So this is actually a highly sensitive test, but it is non-specific. So what does that mean? It means that if somebody's D-dimer comes back negative, then that effectively rules out PE in low-risk patients. So remember, this is a test that's supposed to help you in your diagnosis, but it does not replace clinical suspicion. So if your clinical suspicion is still high, you still might want to investigate further. But if it is positive, then you definitely want to investigate further, as it increases the chances that the patient might have a PE. or it actually can be elevated in other conditions such as sepsis, malignancy, research surgery or trauma, or even in patients with chronic kidney disease. So a positive D-dimer you definitely want to then investigate further. And your next step in patients who do not have a contraindication is almost always to get a CTPA, which is a computed tomographic pulmonary angiography. And this is definitely the preferred imaging in order to make a definitive diagnosis of PE. It is sensitive and specific for PE. However, there are some patients who may have contraindications for getting one of these. If they have a history of moderate or severe contrast allergy, then they are usually not able to get the CTPA because it does require use of IV contrast. This may still be doable in certain situations with pre-medications. Usually we'll use a combination of steroids and diphenhydramine, but there may be some very high-risk patients where even that may not be appropriate. If the patient has a very high risk of contrast nephropathy, in other words, if their eGFR is less than 30, typically those patients should not be getting IV contrast. Sometimes you can also bypass this problem by essentially flushing their kidneys. So by giving them, maybe a bolus of 500 cc's of normal saline before and after. But then again, there are some patients who may not tolerate that, such as your older patients with heart failure. If patients have hypotension or if they have advanced heart failure. So those patients are typically may not be able to get a CTPA, but for almost all of your patients, otherwise you want to get it in order to make a definitive diagnosis of PE. So for the patients who cannot get a CTPA for any of the above mentioned reasons, we can actually do a ventilation perfusion or VQ scan. And this is very much reserved for patients with a contraindication to CTPA, or if they have inconclusive results from CTPA, which is very rare. But typically you'd only get this if a patient cannot get a CTPA. So now that you have made a definitive diagnosis of PE, how then are you going to proceed with treatment? Well, that depends on whether your patient is hemodynamically stable or unstable. So that is the first thing you will determine. Hemodynamically unstable PE, otherwise known as massive PE, is primarily defined by hypotension. So your patient has a systolic blood pressure of less than 90. Or they may have a drop in their SBP of 40 or greater that sustains for a prolonged time period. Or if they have hypotension that requires vasopressors or inotropic support, and that is not explained by other causes. So this PE is primarily what's causing the hypotension. A hemodynamically stable PE then is, by contrast, defined by stable vital signs. So your patient is not hypotensive. The clinical presentation can vary. They may have just mild symptoms, or they may have what is called a submassive PE if they have associated right ventricular strain. They may be completely asymptomatic. So the clinical presentation will vary, but they would be considered hemodynamically stable if they're not hypotensive. So the treatment of hemodynamically stable patients is essentially starting anticoagulation. So sometimes you do have some very high risk patients in whom you do want to start empiric anticoagulation. So we typically give them a one-time 1 mg per kg dose of enoxaparin, and that is because the risk of not being anticoagulated is just so much higher that we don't even want to risk waiting the time that it will take to do a CTPA maybe. So you just want to give them one dose, send them for their CTPA, and then if for some reason it comes back negative, then definitely you don't continue anticoagulation. But if it comes back positive, then you just time your anticoagulation appropriately and go from there. For your hemodynamically unstable patients, your first goal is always going to restore perfusion with IV fluids and vasopressor support, as well as oxygenation. So once you do that and your patient becomes stable after the initial resuscitation, then they can be started on anticoagulation with IV unfractionated heparin. This is quite possibly the best anticoagulation choice initially because it has a quick onset and quick offset. So if for some reason your patient were to become unstable or they started bleeding, you can quickly turn it off and its effects are gone within seconds to minutes. But if your patient still remains unstable following resuscitation, then they will usually qualify for thrombolytic therapy, a TPA. However, you have to make sure that they don't meet any of the contraindications, and that list is pretty extensive. So what you do is you would start the thrombolytic infusion. There's different protocols out there, and different hospitals do it differently. Some will drop the rate of unfractionated heparin, but still keep it on. Others stop it and give TPA first to minimize the risk of bleeding. That's the approach that I prefer as well, to discontinue IV unfractionated heparin if you've already started it, and start the patient on IV alteplase 100 milligrams, which is given over 2 hours. And then you resume anticoagulation with IV unfractionated heparin after completion of IV alteplase, as long as the ABTT is less than twice its upper limit of normal. And you want to avoid low molecular weight heparin or oral agents for at least 24 hours. And that is, again, to make sure that you have options if the patient were to bleed. And given that they just got alteplase, the risk of bleeding goes higher. So if they are kept on IV infection heparin, then if they were to bleed, then we can stop it pretty quickly, and if its effects will be gone pretty quickly, and you can do your other measures to then control the bleeding. There are some other options as well, such as catheter-directed techniques, ultrasound-assisted thrombolysis, and embolectomy, but usually those require specialists who have, studied in that area and have experience in that area. So now I'm going to be talking about anticoagulation treatment options for hemodynamically stable patients. So these are patients who were hemodynamically stable to begin with, or the ones that were hemodynamically unstable but got the resuscitation and maybe even got TPA but are now stable. If they got alteplase, then it's been more than 24 hours that they've gotten it and are very much stable in terms of their vital signs, and there's not a high risk of bleeding. So for these patients, the preferred option is DOACs, or direct oral anticoagulants. We have 4 currently on the market: rivaroxaban, apixaban, dabigatran, or edoxaban. And these agents are actually preferred by the CHEST guidelines because their efficacy is similar to warfarin, but their bleeding risk is actually lower than warfarin, especially intracranial bleeding, and there's a reduced need for monitoring. So rivaroxaban and apixaban are actually used by themselves. They both have a loading period where you get a higher dose. So that's 21 days for rivaroxaban and 7 days for apixaban. And then you go down to a little bit of a lower dose that you continue for however long you need to be treated. The Bigatran and edoxaban are slightly different for that matter. If you want to start these two medications, you have to give the patient at least 5 to 10 days of a parenteral anticoagulant. So that could be a low molecular weight heparin or IV unfractionated heparin. This kind of defeats the purpose because once the patient is stable, they're ready to go home, and you want to just start them on an agent that they'd be able to continue at home. Yes, the patients could be started on enoxaparin and they'd have to give themselves the injections for, let's say 5 or 6 days at home. It's still kind of a pain. So it's very rare that you would see either of these agents that are used. Usually you'll just see a rivaroxaban or apixaban because you could just start the patient on them with instructions on how long they need to take the higher doses and then go down to the lower dose, and there you go. So for some patients, DOAC may not be appropriate, and typically it's patients who are able to take PO medications, but for some reason the DOACs are not covered by their insurance, or they have a very high copay. Then warfarin would be a good option. You do need to bridge it with enoxaparin. So in this case, you would have to teach them how to use the injections, and they'd have to start both warfarin and enoxaparin, keep taking the enoxaparin injections until their INR is above 2, and they'd follow up with their PCP or Coumadin clinic. For patients who just are not appropriate for oral anticoagulation therapy, these could be people who have poor PO intake, or who are not able to take anything orally, or have malabsorption issues. Then low molecular weight heparin or enoxaparin is an option. These are sub-Q injections, so the patient is able to do those at home, whether they give themselves the injections or have someone else do it. But it's a relatively easy way to keep yourself anticoagulated, though these are injections, so less easier than taking PO meds, but it's still a fairly reasonable regimen. And then we do have fondaparinux, which is a synthetic heparin, so it is expensive, so it's typically reserved for patients who have a history of HIT or heparin-induced thrombocytopenia, because those patients cannot take our regular heparin products. So next point is really just to talk about the duration of treatment, which would be typically decided by if your patient ends up seeing a hematologist or even just PCP. Typically, we can give a recommendation of how long it should be in the hospital, but there would be another person looking at their risk factors and if they do any further workup to really determine how long the patient needs to be on it. But it's typically at least 3 months. And if the risk of recurrent thrombosis is higher, then maybe even 6 months. Sometimes it's extended to 12 months if a patient has persistent but a reversible risk factor. So let's say if they have a malignancy that is being cured, or if they have other risk factors that lasted for a long time or that are currently ongoing but will be gone eventually, then you treat them for that amount of time. And then for some patients, they may qualify for indefinite anticoagulation if they have unprovoked DVT. So unprovoked DVT or PE is when you don't have a known cause for why they developed it. So, if the patient just recently had surgery or hospitalization, if they're on estrogen therapy, if they were pregnant, those are known specific risk factors that are not going to last forever. So those are provoked risk factors, and the patient is typically treated for 3 to 6 months, and given instructions on try to be very careful if they're ever exposed to the similar risk factors again. However, if you weren't able to find any risk factor, then that is an unprovoked DVT or PE, and those patients, given their risk of bleeding, if it's low, can actually be on anticoagulation for life. Patients who have recurrent unprovoked VTE, who have active cancer or antiphospholipid antibody syndrome, also typically require lifelong anticoagulation. So this is it for this video on PE. Do let me know if you have any questions or if there's anything else that you want me to address. I will be doing 2 more videos on just more details and discussions on the specific anticoagulants themselves, just to give you more information on those. And then I'm happy to take any of the suggestions for any of the topics that you may have. All right, thank you.